I think in the interest of time, let's go ahead and get started. This afternoon, we have the guest speaker, Dr. Frank Smart from LSU New Orleans. He's Chief of Cardiology there and Professor of Medicine, as well as Gerald Berenson, Professor of Preventive Cardiology. But before I come to introducing Dr. Smart in more detail, I would like to say a few words about Dr. Holoubek, late Dr. Holoubek. He was born in 1915 and he passed away in 2007. He is a founder, one of the founders of LSU School of Medicine here in Shreveport. The Joe Holoubek, MD endowed professorship was established in 2006 by his family, Holoubek family, in honor of Dr. Holoubek. Dr. Holoubek was the first internist to establish clinical cardiology practice in the Twin Cities of Shreveport-Bossier. He was also instrumental, as I said at the beginning, in establishing the School of Medicine here in Shreveport. He was born in Nebraska in 1915. He obtained his medical degree from University of Nebraska in 1938. Married to Alice Baker, who was also a physician, whom he met at the Mayo Clinic during a summer fellowship. And that was a long courtship. There was a few years of courtship and very romantic correspondence between them during those 2 years. And then they did a residency and fellowship at LSU New Orleans. Following that, they moved to Shreveport to set up joint practice together, husband and wife, in medicine and clinical cardiology in 1945. There wasn't a whole lot of cardiology back then, as you know. The courtship of two doctors, a 1930s love story of letters, hope, and healing by their daughter, Martha Holoubek Fitzgerald, has been published several years ago. And it makes a very interesting reading. There were 800 letters, as I said, between them during those 2 years of courtship, and they make very interesting reading. These days of telephone and internet and email, we don't have any time to write such letters, let alone express those kinds of. This is the book I'm talking, and this is Alice Baker, and this is Joe Holoubek, as he was commonly known as Joe, Dr. Joe. And these are, I quote from the letters between them. This is from Joe to Alice. There is still much to be done in the field of medicine, and let us do our share, not for private and personal gain, but for the benefit of the profession and the multitude. And then this is 17 days later, she responds to him, I hope I can someday be worthy of being called a real doctor, which to me is the ultimate of human goodness, kindness, and helpfulness. I thought that was very good. I mean, these days, we were just talking, most of the time people tend to ask, what is in it for me kind of thing. So that is really very philosophical to ruminate or think about. In 1963, Dr. Holoubek, affectionately known as Dr. Joe, was named chairman of a committee to explore the establishment of a medical school here in Shreveport. As the head of that committee, he worked very hard. From what Dr. McDonald told me once, medical school was finally established in Shreveport, as you know, with its first class of students enrolled in 1969. He was on the visiting faculty here in the Department of Medicine and retired as clinical professor emeritus in the Department of Medicine. Upon Dr. Holoubek's death in 2007, late Dr. McDonald, our former chancellor, had to say this. Dr. Holoubek was a giant figure in the history of the LSU School of Medicine, Shreveport. He had a vision for a medical school in Shreveport and worked tirelessly to make that vision a reality. Every graduate from our medical school perpetuates his legacy to the community, the state, and the medical profession. Now, coming back to our guest speaker this afternoon, Dr. Frank Smart, who, as I said, is professor and the chief of cardiology division at LSU School of Medicine in New Orleans, our sister school. He is also the director of the Center of Excellence for Cardiology, Cardiovascular Diseases and Sciences, and endowed professorship of Gerald Berenson Professor in Preventive Cardiology. Dr. Smart went to Southeastern Louisiana University. He actually attended 1 year of undergraduate at Tulane, then he moved to Southeastern Louisiana where he obtained his bachelor's degree in science and then MD degree from LSU School of Medicine in New Orleans. And that was followed by both internship and residency at Auction Medical Center in New Orleans, and then that was followed by cardiology fellowship at Baylor College of Medicine in Houston, Texas. He is a nationally recognized expert in heart failure and cardiac transplantation. Over the years, Dr. Smart has directed multiple heart failure programs, including those at Baylor College of Medicine, Houston, Ochsner Foundation Hospital, New Orleans, and Tulane University, New Orleans. Before joining LSU New Orleans in 2011, Dr. Smart was chairman of the Department of Cardiology at 3 community hospitals which are affiliated with Mount Sinai School of Medicine in New York. He was also the associate professor of medicine at Mount Sinai School of Medicine during the years 2006 and 2011. He received numerous awards and honors. I listed only a few here. He is AOA, Ochsner Fellows Alumni Association Outstanding Fellow, Hurst B. Hatch Award for Outstanding Teacher of the Year, LSU New Orleans, Tulane University Award for Outstanding Teacher, Didactic Teacher of the Year, LSU Master of Physician Assistant School, and he's currently the president of Louisiana Chapter ACC. As a result of that, he is also a member on the board of directors of American College of Cardiology. Dr. Smart is actively involved in both clinical and translational research in the fields of heart failure and cardiac transplantation. His current research is focused on renal denervation and its effects on blood pressure and heart failure. He's a recognized expert, as I said, in heart failure, an outstanding clinician and teacher, as well as a prolific writer with over 135 original articles and several book chapters and over 160 abstracts to his credit. As head of the Division of Cardiology at LSU New Orleans, Dr. Smart has developed a strong team active in research, teaching, and clinical practice. These are all the qualities that would have endeared Dr. Smart to late Dr. Joe Holoubek. Dr. Smart's topic for Grand Rounds this afternoon is NOACs, that is novel oral anticoagulants. Are they all the same? Dr. Smart.
Thank you very much for having me, and I had the opportunity to meet Dr. Holoubek's, some of his family yesterday, and I will say that I was honored before and after hearing more about him and learning some of the things that he did, and actually those quotes from those letters, I hope that one of these days I will be able to do justice to really champion physicians like Dr. Holoubek. It's just amazing that people can be so very just giving of themselves like that, and during times that it was pretty hard to do. So again, my pleasure to be here. I'm going to talk about oral anticoagulants today, and Dr. Reddy's already told you I'm a heart failure person, so you would typically go, well, gosh, what are we doing with a heart failure guy talking about anticoagulation? I hope that I can explain that in a moment. I don't have any disclosures with regard to NOACs. I do have some royalties from a heart failure drug that we designed and Bristol Myers Squibb purchased it, and I was actually an expert witness against Rivaroxaban and Xarelto for a brief period of time. I don't do that anymore because I really don't like encountering the legal system any more than I have to. My son is a lawyer, so I even avoid him except at holidays. I'm going to show you the last slide first and then see how we can work from there. So this is what I hope at the end of this talk that you would agree with me that no reasonable clinician familiar with the data would ever prescribe Rivaroxaban in a once daily dose for non-valvular atrial fibrillation. And that's a pretty bold statement because this is a very big and busy drug. I mean, it was the #1 selling novel oral anticoagulant for a long time. It has just very recently been displaced from that spot, and it's still incredibly heavily marketed. So I'm going to tell you how I came about this, and then try to take you through some of my path of discovery and what I've learned and share with you some of the data. So I had a 66-year-old lady that I was taking care of with non-valvular AFib. You can see she had hypertension and diabetes. She was well treated and well compensated. Her CHADS VASC score, we'll get into in a minute, was high, so we went ahead and put her on an oral anticoagulant. So her CHADS VASC score was 4, her HAS-BLED score was 2. She started Rivaroxaban at 20 milligrams a day, which was the appropriate dose for her creatinine clearance. And then 3 weeks later, she was admitted in extremes with a hemoglobin of 5.6 grams. And it was very revealing to me because I thought, I didn't expect this. There's nothing that I could have done better. She didn't have a preoperative gastroscopy, but is that really necessary? I mean, she had no history of bleeding, no history of ulcer, no complaints, stable hemoglobin. So really I thought, gosh, this is just, something's wrong. So I started digging into the literature to find out a little bit more about what I could have done differently. And the things that I learned were pretty startling, and I'll share them with you. First, atrial fibrillation, as you all know, is the most common arrhythmia in the United States. 3 to 4 million people is a conservative estimate. That's why I put it up there. There's some people that say as many as 6 million patients in the U.S. have AFib. Again, 2% of people younger than 65 and 9% of people older than 65. African Americans are slightly less likely to have AFib than those of European descent. And it's very expensive. It costs the U.S. healthcare at least $7 billion, and that's not including, that's direct costs, that's not including lost wages and things like that. The AFib and cardiovascular costs, so this is the average cost comparison from all cardiovascular expenses with and without AFib. You can see that AFib, particularly on the inpatient side and even on the outpatient side, greatly escalates the amount of money that we spend on patients with cardiovascular disease. It's a complication that routinely happens after bypass surgery, almost 25% of the time, and we're confronted with it every day and all the time. We were talking this morning about the rapid AFib and new onset AFib patients that come in and require therapy and end up spending time in the hospital and going out with some of these very complicated drugs. The reason, obviously, we're so concerned about it is that thromboembolic stroke in AFib is a problem, so that the increased stroke risk is about 4 to 5-fold, and it accounts, AFib accounts for 15% of strokes in all ages and 30% of people over the age of 80. You may have recently seen, these are probably underestimates. There was a recent article about implantable monitors for atrial fibrillation in occult CVA that showed that we probably are underdiagnosing occult AFib almost 12 to 15% of the time. So we really are missing a lot of it. Systemic anticoagulation reduces the risk of the ischemic stroke, but obviously you trade off the risk of bleeding and intracranial hemorrhage. And we use these guidelines to try to help us to decide when it's appropriate to give a patient an anticoagulant and which one to give. Now, for the students and younger House officers in the room, guidelines aren't rules. Guidelines are guidelines. You can do whatever as a physician and a license to practice medicine. You don't have to follow guidelines at all. You can choose whatever direction you'd like that you think is best for your patient. You certainly are at a safer point from a medical legal perspective if you follow guidelines, and they really do help to take patients and make practice simpler by giving us a guidepost with which to judge ourselves. But so make sure that we don't just talk about guidelines and say that they're rules, and if I say that today, please just throw something up here, a piece of chalk or whatever, and we can move forward with it. I don't want to make it sound like these are rules for doing anything. I told you a minute ago about the CHADS-VASc score and the has-bled score. If you don't know about this, you probably have spent the last few years not practicing clinical medicine, because this is something that is very routinely used these days. As a matter of fact, there's now at least, I think, 3 or 4 different apps that you can walk around with on your phone and plug clinical characteristics in, and they will spit out CHADS-VASc and a has-bled score. But for the most part, you can see that it just spells out its name. It's a total of 9 points. The has-bled score is more contrived, and they needed to equal 9 points so that you would have some sort of a clinical equipoise, that if your CHADS-VASc score was 6 and your has-bled score was 2, you favored anticoagulation. If your CHADS-VASc score is 1 and your has-bled score is 5, you favored not systemically anticoagulating people. And that's been the balance that we've tried to look for, although you can see that some of these are a little bit on the soft side, like I said a moment ago. The idea about anticoagulating people is this is what should be considered. So we right now will anticoagulate people who have a CHADS-VASc score of 2 or more, and I'll show you that in a little bit more detail. We talked last night, and I think one of the things that I've learned is it's so vital to talk to your patients about doing this, to let them be a part of the decision that we're going to anticoagulate you, we're going to give you a medicine that's going to thin your blood, and by golly, when we thin your blood, you're more likely to have a bleed. And so please be aware of this, look for these side effects, and make sure you talk to us if there's anything that happens. Now, warfarin is the gold standard of which all anticoagulation was based on. Warfarin, you've heard people refer to as rat poison. It actually is and was initially marketed as a rat poison. It was from the Wisconsin Alumni Research Foundation, which is where warfarin comes from. This magical rodenticide was really good because what it did was the rats ate it in your home and developed internal hemorrhaging, sought water, left your home, and died somewhere else. So they didn't die in your basement or in your attic or in your walls. And so that was one of the novel ideas behind it and why it caught on so quickly. Warfarin, when used appropriately in the correct doses, prevents stroke risk in Afib. So here is the risk with CHADS-VASc score going from 0 to 9, and you can see that as the CHADS-VASc score increases, those people without warfarin fare worse with strokes per year than those people who are on warfarin. Now, you'll notice that these two curves diverge at around 2, and that's the important point, because I told you that after 2, we start saying that there's a benefit to systemic anticoagulation. Now, this slide says warfarin reduces stroke risk in Afib. The next one is a little bit of a parody on that, and it says that well done warfarin reduces complications. So that warfarin is a hard drug to use. We'll spend the next few minutes talking about that. But it's very, very, very important to remember that when we are talking about these benefits, we're talking about managing an INR between 2.0 and 3.0. When your INR starts creeping higher, you can see that the intracranial hemorrhage risk really starts to skyrocket as you get higher. And so at an INR of 4, which doesn't seem that high, your intracranial hemorrhage risk is double what it is if you're not on warfarin. Over here, you can see that if you look at this black line, which is well-managed warfarin, you are doing better with well-managed warfarin in AFib than you are if you're not on warfarin. However, if your warfarin is poorly managed, this gold line and this sort of light blue line, you can see that your overall outcome is worse. So this time in therapeutic range, or TTR, is an incredibly important component of doing warfarin. Well, that's one of the things that I didn't know when I started looking. I couldn't have told you what the TTR for my practice was at the time. I know now, but I also know that TTR is one of those important numbers that we should all be looking at if we use warfarin in any way, shape, or form. Now, this is a slide that talks about drugs that interact with warfarin. You're not supposed to be able to read it. You're just supposed to go, wow, that's a lot. Almost every drug has some degree of interaction, and most classes of drugs have multiple interactions. The time in therapeutic range, again, has to be very well monitored. Now, it's interesting that a good Coumadin clinic time in therapeutic range is 70 to 74%. And when patients, motivated patients, are allowed to do this at home, their time in therapeutic range is even better than that. It's 75-ish%. So if you can possibly get your patients to self-manage with their own device at home, it works extremely well, sometimes as high as 80%. And unfortunately, it's expensive and many insurance companies don't pay for it. But again, the time in therapeutic range is a proportion of first, how compliant your patient is, second, how well we've educated them, and third, how frequently they monitor. So if they monitor frequently and at least weekly, you can see that there is an added benefit to TTR, higher percentage rates. Now, warfarin has a multitude of effects in the coagulation cascade, and that's a good and it's a bad. It makes that it's a good anticoagulant. It makes it a complicated anticoagulant. The drugs that we're talking about today, the novel oral anticoagulants, have single targets, either a direct thrombin inhibitor like dabigatran or a factor Xa inhibitor like Rivaroxaban, Apixaban, and Endoxaban. And so we're going to talk about both of these, but we're going to focus on the Xa inhibitors for the most part. Now, there's a yin and a yang for everything we do, and the novel oral anticoagulants are no different. The drugs are good because they have a fixed dose with no need for monitoring. I'm going to say kind of no need for monitoring. There's no adjustment based on diet. There are limited medication interactions when you compare it to warfarin. There's much less patient variability, and they have typically been shown to be as safe or safer than warfarin for an anticoagulation effect. The yang is, at least with the Xa inhibitors, as of today, there's no reversal agent. There's one that's been submitted to the FDA, turned down, and now resubmitted a couple of weeks ago. It's difficult to tell when the drug is at a safe level. It's not impossible, I might add. So a partial thromboplastin time isn't helpful, but a prothrombin time in an INR is helpful. So if your patient comes in and they're taking Rivaroxaban and you draw a prothrombin time and it's not prolonged, you do not have drug effect on board and you can feel safe operating on these people. It's incredible how frequently patients with severe trauma are not taken to the operating room because of these agents right now. It's very frightening, and a reversal agent is something that really is a very necessary next pharmacologic step. Renal function, as you're going to see in a minute, has a significant effect on levels. Bleeding risk is obviously something that we have to deal with, and then the drugs are expensive, somewhere on the order of about $400 a month, where warfarin is about $6 a month. Now, I'm going to show you the slide quickly, and then I'm going to come back to it later on. But what I want you to understand is, again, in pharmacokinetics and pharmacodynamics, that we have a minimal effective concentration, we have a maximum safe concentration, above which we have side effects, below which we don't have any therapeutic drug effect. The therapeutic window is in this green area, and as we give a dose of drug, it starts at 0, it goes up to its maximum plasma concentration, it falls down again, we give another dose, and it comes up. So that's all I want you to know from this slide is the mechanics of a pharmacodynamics and pharmacokinetics profile. We're going to, like I said, revisit this in just a moment. Now, the novel oral anticoagulants started with dabigatran. It was the first one released in 2010 and approved for Afib and non-valvular atrial fibrillation. Dabigatran was, again, is a direct thrombin inhibitor, and it was, it was used in the RELY trial, which, let's go back one more, I'm sorry. In the RELY trial, which was the sentinel study that got the drug approved. It was approved at a dose of 150 milligrams twice a day, or 75 milligrams twice a day if your creatinine clearance was between 15 and 30. Again, nausea and dyspepsia were fairly frequent side effects of dabigatran and really were limiting the use of it in early stages. It's still a very commonly used anticoagulant today, and it actually has a fairly decent drug profile. Rivaroxaban was the second drug that came out. It was the first factor Xa inhibitor, and it was approved for DVT prophylaxis in 2011. Now that's important. In just a minute, we're going to talk more about why DVT was approved and important that way. It was approved for non-valvular Afib in November of 2011, and the ROCKET AF trial was, again, the sentinel paper that landed the drug in front of the FDA for its approval. It's published in New England Journal of Medicine. And interestingly, Patel is the first author, but Dr. Rob Califf is the senior author. Dr. Califf was the director of the Duke Clinical Research Institute at the time. DCRI clearly has a very proficient track record for doing a good job. And Dr. Califf was soon to be named to be the director of the Food and Drug Administration. So the drug published in the New England Journal had a lot of things that was good about the study. It was a very large study comparing Rivaroxaban to Warfarin, and it was, again, a well-designed trial. Now, unfortunately, well-designed and well-implemented aren't always simultaneously the case. And the New England Journal of Medicine published it, DCRI ran it, the FDA approved the drug. So what could possibly be controversial about what I told you a minute ago and why you shouldn't use Rivaroxaban in patients for non-valvular Afib in the once daily dose? The controversy started when Rivaroxaban came forward. I told you a minute ago it was approved for DVT first. That's because it did not go through the Cardiorenal Advisory Board. It went through the hematology section of the FDA, which is typically dealing with cancer drugs that there are no other substitutes for. So the hematology section is a little bit more lenient with regard to new classes of agents and trying to get them out there faster to help patients. And that's what happened with Rivaroxaban. Then right on the heels of that, in July, in November, they went to the Cardiorenal Advisory Board for the non-valvular Afib indication. So based on the DVT approval, they went to non-valvular Afib. Now, even before the ROCKET trial finished, there were some questions that were coming up about the Warfarin arm and how well those people were being managed. And so I'm going to try to explore some of that with you as we traverse down the rabbit hole of Alice in Wonderland to see just how far those things go down there. So first, Rivaroxaban was approved at a dose of 20 milligrams once a day and reduced to 15 milligrams daily if your creatinine clearance was between 15 and 50. It's not indicated for people with a creatinine clearance less than 15. The Warfarin control group was done with the Alere INR home monitor and laboratory values drawn at 12 weeks and 24 weeks to validate the Alere device. The time in therapeutic range in the ROCKET AF trial was 55%. Now, I just told you a minute ago, 70% is what we ought to be shooting for, and that anything less than 40%, Warfarin was actually hazardous to you. You shouldn't be on it at all. And here the TTR is 55%. This is the lowest of any of the NOAC trials. I'll show you in a minute why, but it's substantially low enough that it called significant question at the FDA. So there was much discussion surrounding this. I'll share some of that with you in just a minute. The TTR is based on the trial control group using the Alere device. And again, with a home monitoring device, our TTR should have been closer to 70. Well, how does the drug interact? And where are we with some of these considerations of dosing and renal insufficiency and things like that? And so I put this up here just for example's sake, that here's a 68-year-old female, 165 pounds with a serum creatinine of 1.2. And we have another 68-year-old female who now is 156 pounds. I'm not dyslexic, I just moved it around a little bit. And the serum creatinine is 1.2. Doesn't seem like that's that big of a difference, but the creatinine clearance here is 52.83. Here is 49.95. So the dose of Rivaroxaban is 20 milligrams daily here and 15 milligrams daily here. Those two patients, in my clinical opinion, are exactly the same. There's no difference between those two individuals, and yet the numbers are what the numbers are. So are we under anticoagulating this person, or are we over anticoagulating this person? Clearly, the weight can be different. If you go by the hospital weights in our hospital, they can vary 20 pounds on any given morning. So, it's challenging to try to base your drug dosing on some of these things. More importantly, along the way, what we started discovering was that prior to the completion of the trial, the Alere device was having problems. And after the trial's publication, but prior to a lot of the FDA discussions, the Alere people had reported to the Food and Drug Administration that their device was malfunctioning, that it was giving levels that were incorrect. And it actually was recalled in March of 2016. So the device was recalled from the market in 2016 by the FDA. The device malfunction was responsible for even worse warfarin control in Rocket AF than the 55% that they published. And how much worse? We don't know. That's the problem, is we really don't know. So here is this is from the paper, and actually from a subset analysis that was put forward by the FDA and by DCRI. And so what we have across the x-axis on top is the laboratory measured INR, less than 2, 2 to 3, 3 to 4, 4, and the total. Here we have the Alere device measured INR, less than 2, 2 to 3, 3 to 4, and 4. We're obviously looking for congruence here. And I'm going to point to this group of patients where the laboratory INR at 12 weeks, and actually it was a little worse at 24, the laboratory INR at 12 weeks was greater than 4, but in those patients, these 47 and 172 were either told to increase their warfarin or to keep it the same. And so in 219 patients with an INR over 4, they were told to either keep constant your warfarin dose or increase it. And so obviously that led to control problems with the Rocket trial. More importantly, when the FDA, and this is from the Food and Drug Administration, as you can see, this was a slide that was presented in the November 2011 discussion where the FDA weighed in on the drug and its applicability and approvability. The Food and Drug Administration said, okay, the TTR is pretty poor. Tell us why. And if you look, most of it is related to this very poor TTR from the Eastern European patients, where that represented almost 39% of the patients. The Asian Pacific patients a little bit better, Latin American a little bit better still, Western Europe better, and then the North American patients 64. So you can see that we're getting better as we get more of the North American patients with tighter control. And the FDA said, and this is their quote, if only North American patients were considered, Rocket AF would have not met the non-inferiority test for the trial being positive. So Rocket AF was now called to question. Is the trial positive or is it not? If we looked at a real TTR and a TTR based on this Alere device working properly, it would not have been positive. So the FDA and Duke Clinical Research Institute went back and mathematically modeled the INR, and this was all called to question in the British Medical Journal. And the response was, again, to do these mathematical models. And what they did was to say, well, had the Alere device not worked improperly, the study would have more than likely shown the similar results. And that has to sit with clinicians and investigators in a fairly poor fashion. If mathematical modeling was adequate, why wouldn't you do it all the time? Why do you do a clinical trial? Because many, many times, mathematical modeling leaves us short. That's why in my career as a clinical researcher, I've seen many drugs that sounded really good and looked really good in the animal lab go forward and actually hurt people. My first clinical trial was in the CAS trial where the placebo arm fared 3 times better than the treatment arm. So we don't set out to hurt people, but again, mathematical modeling can only take you so far. The FDA and DCRI created these mathematical models, and Dr. Patel, the lead author, supported this in a letter sent to the New England Journal of Medicine. In fact, there was a significant call at around this point in time for the New England Journal of Medicine to embargo the manuscript and to label all results as controversial and non-confirmed. It was interesting that after the British Medical Journal report, Harlan Krumholtz from Yale reported that it should be an immediate expression of concern by the NEJM. Later, he was asked by HeartWire to weigh in on the mathematical model and whether that satisfied his concern. And Dr. Krumholtz said his response to the new data released by Patel alleviate his worries. Krumholtz told HeartWire and actually subsequently the New York Times that although the DCRI provided a nice analysis to prove their trial valid, he wished they had done further analysis and stressed the data should be made public as the why not share the data so others can look at it and do their own mathematical modeling. To date, the data has not been shared. So when, again, the New York Times in March of 2016 called to question the New England Journal of Medicine, they asked about the laboratory assessment and the TTR number, and the New England Journal had not been informed of this, so that the editor of the New England Journal said, at the time we published the letter, we did not know that it existed. It refers to this data of the laboratory discrepancy versus the Alere device discrepancy. So you can see now that there's at least not a small amount of questions that have come up about the validity of the trial and whether or not we have enough information. The FDA typically takes 2 physician scientists and they assign the trial and the drug to those scientists. They do a review and give an expert report back to the full FDA committee, who then decides to approve the drug or not. Well, the 2 primary reviewers for Rivaroxaban said that Rivaroxaban and non-valvular Afib should not be approved based on the Rocket AF trial data. The feeling of the FDA reviewers was the dose was too high, and had warfarin been well controlled, the bleeding complications in the Rivaroxaban arm would have been excessive. This was discussed with Dr. Califf, the principal investigator of the trial, who supported the notion that the dose was too high and a twice daily dosing should be considered. This is all in the FDA transcript. The FDA soon after was lobbied by the company to consider the drug as a second-line therapy. The reason this was going forward is that the FDA decided they did not have the authority to mandate the dose to be tested by the drug companies. So that what they said was, we think the dose is too high. We think you chose too high of a dose. We think that this is a twice-a-day drug crammed into a once-a-day dosing schedule, and we think you should redo it, but we don't have the authority to tell you you have to. And so then the company said, well, okay, we don't want to redo it. We've decided that this is our sweet spot and this is where we're going to stay. So we go on then, this is again from the FDA transcript. Some on the review panel, some on the review team, as well as several members of the advisory committee, suggested that if Xarelto were to be approved, it be restricted to second-line therapy. The rationale for this suggestion seems to be as follows. It's not clear that outcomes were as good, we just talked about. Pradaxa has shown to be superior, and therefore Xarelto should only be used in people who have a difficult to control INR, or for whatever reason they can't take dabigatran. So this was the proposal that landed it in front of the committee for a vote, and the committee voted. And they voted by one vote to move forward with approval. The company then challenged the FDA and said, wait a minute, tell us a clinical scenario that you think would warrant converting somebody from dabigatran, Pradaxa, to Rivaroxaban. And the FDA said in this statement, that's about a page and a half further down, the division did not adopt the suggestion because no specific clinical scenario could be identified that should prompt a healthcare provider to switch a patient from warfarin to Pradaxa or Xarelto. Or rather, from warfarin or Pradaxa to Xarelto. And so you can see that this cascade, the snowball, as it starts to roll down the hill, is getting bigger and bigger and bigger, and there's kind of almost nothing that's stopping the snowball. Now, I promised you we were coming back to this, and here's where I want to focus again. Anticoagulants have a narrow therapeutic window. Rivaroxaban has a particularly narrow therapeutic window. It is the narrowest of all the novel anticoagulants. And remembering on top of this curve is side effects, below this curve is no drug effect, time zero, peak dose, repeated doses along the way. The sweet spot of this therapeutic window is this green block here. This is a graph from the Canadian Journal of Cardiology, and this is dabigatran, this is Rivaroxaban, and this is Apixaban. Again, for the ease of looking, the shaded area is that therapeutic window. That's the sweet spot. That's the spot that we want people anticoagulated in. We can only focus on this black dashed line in each of these curves. That is the routine, typical atrial fibrillation patient. We don't need to talk about the extremes. Let's just focus on the routine patient. And what you see is that with dabigatran, we give a dose, the level comes up, we exceed this maximum effect a little bit for maybe about 5 hours. It falls back down, we give the second dose, and it's back up again. If you look at Apixaban, we give a dose, it's up, it's down, it's up, it's down, but always within the therapeutic window. And look at Rivaroxaban. Here we give a dose, and we skyrocket it up to 2.5 times this therapeutic dose, and for over 12 hours out of a 24-hour day, the curve is above the therapeutic window. And it falls back down to the lower end of the therapeutic window at 24 hours. So you can ask yourself, you should ask yourself the question, what the heck? What happens here? I mean, you know, that's a lot of anticoagulation effect. The half-life of Rivaroxaban in a normal person is 5 to 9 hours. In elderly subjects, it's 11 to 13 hours. So you can see why the FDA said, wait a minute, you're taking, let's take 9 hours at the outside. You're taking a 9-hour half-life drug and giving it once a day. The math doesn't work. It just can't work. So giving a 1 hour, once a day drug is crazy. So why would you do that? Why would you give it once a day if it's a twice a day drug? Well, the reason is because it's a marketing ploy. And the marketing team drove this. The scientists didn't. And the marketing team pushed it forward and said, look, if we're a twice a day drug, we're no better than dabigatran. We don't have a chance of winning the market. We need to be once a day. And how many of you, everybody in this room, has seen Rivaroxaban, Xarelto commercials for once daily dosing? It's true, we do. But again, we have to deal with this 2.5-fold excess in anticoagulation effect. So despite the scientists, the physicians, and the FDA asking for a rocket booster, now this is actually Dr. Califf's communication to the FDA that he recommended that the company they do rocket booster. He had already named the trial. They funded it. And the company decided that they were not going to do that because they would lose their market leader status, and the marketing strategy, as you can see, continues. Now, to the credit, Rivaroxaban is not a bad drug. Rivaroxaban 20 milligrams a day is a high dose of a drug. The newer Rivaroxaban trials are twice daily. So for acute coronary syndrome, it's a low dose given twice a day with aspirin, and it's actually shown to be beneficial so far. Now, after the drug's released, we start looking at things. So here is from JAMA Internal Medicine, stroke, bleeding, and mortality excess in Medicare beneficiaries. So this is a retrospective look at over 100,000 people that were taking these drugs. And what it showed is that treatment with Rivaroxaban, 20 milligrams once daily, was associated with statistically significant increases in intracranial hemorrhage and major extracranial bleeding, including major GI bleeding, compared with dabigatran, 150 milligrams twice a day. Apixaban now comes along. It's later in 2012, and its dose reductions, it's 5 milligrams twice a day with 2.5 milligrams reduced for renal insufficiency, comparing it to atrial fibrillation, stroke risk, and warfarin. And Apixaban now has been shown to be superior to warfarin for thrombosis, stroke risk, and superior to warfarin for bleeding risk. Importantly, Rivaroxaban was equal to warfarin, but that was based on poor TTR data. Apixaban versus Rivaroxaban, there is a trial, and even though the numbers aren't staggeringly high, the Apixaban trial, the Apixaban patients were half as likely to have significant bleeding abnormalities as the Rivaroxaban patients. Apixaban has actually been compared to aspirin in people who couldn't take Coumadin or other vitamin K antagonists, and it was as safe as aspirin in those people who couldn't take warfarin. The Endoxaban was looked at, it's a once-a-day 10A inhibitor, and it has a 10 to 14-hour half-life. So you can see a little bit, twice the half-life of Rivaroxaban. So it's probably better than the Rivaroxaban issue with the once-a-day dose. So if you really had to do once a day, Endoxaban is a great drug, and actually it is the least expensive of all of the NOACs. Endoxaban is, again, high dose, low dose, and warfarin. You can see low dose fared better, and so the lower dose of Endoxaban was adopted, and that's currently what's used. I told you a little bit about the treatment tidbits before, about the partial thromboplastin time not being helpful, but the prothrombin time being helpful. And again, I told you there is a 10A inhibitor that's coming out pretty soon. Remember that abrupt discontinuation of any of these drugs increases your stroke risk pretty substantially. And so you have to really think about what you're going to do when you discontinue these agents, and also tell your patients that, listen, if you decide to stop this drug, let's talk about it, but you need to make sure you let me know, because this is drastically going to increase your risk. So what I'm hoping is that you will see that 20 milligrams once a day of Rivaroxaban is a very risky agent for non-valvular AFib. And I wanted to just kind of hone in on the message for just a second. Just because the FDA seemingly approved it, you never know the full story. Just because the New England Journal of Medicine published it doesn't mean that it's without controversy. And just because Duke Clinical Research Institute was the shepherd of the trial, again, doesn't mean that everything was done perfectly normally and perfectly well. You should always form your own opinion. And I think that my message to myself was I needed to read more about it. I didn't know that much about it. My basis for using Rivaroxaban was based, like most people's are, on the pretty blue folder that was handed to me by the drug rep. And I never researched it and never looked that much at it. And so I'm glad to be here and share this with you today. So now, as a wrap-up, what I'll say is, with all the alternative treatment options that are available that have a better risk-benefit profile and no cost difference, no reasonable clinician familiar with the data would prescribe Rivaroxaban in a once-daily dose for non-valvular AFib. Thank you.
Well, we have a plaque to present.
Oh, well.
It says LSU Health School of Medicine, Shreveport, Louisiana, Joe Holoubek, MD, Professor, Department of Medicine, Division of Cardiology, presented to Dr. Frank W. Smart, September 12, 2017.
Thank you very much. I appreciate it.
Any questions?
I have an observation. In studying medication adherence, all of these trials are assuming that patients are very adherent. And some of the latest research is a lot of unintentional patient problems or overdosing by 20 or 30%. I don't know where the sweet spot is. If you miss a dose, you go out of town, you forget your pills. Or you're older and a little disoriented and you take 2 of them. What does that do to the sweet spot?
If you take 2 Rivaroxaban, there is no more sweet spot. If you take 2 Warfarin, you probably are going to be okay, but again, on a milligram basis. These drugs are more potent, and there is a risk. There have been now 2 studies to look at the argument that because Rivaroxaban is once daily, the compliance is better, and that is not the case. So these drugs actually fare very well at twice daily dosing, and people are just so happy to get off of warfarin. They would stand on their head and spit nickels for the most part. I mean, they would do anything, and the compliance is actually pretty high, much higher than it is with other agents that like cholesterol-lowering agents, statins, and things like that. And again, at 61 years old, stand in front of you, probably the most non-compliant person I know. I've never taken a course of antibiotics correctly in my entire life. I feel better and I stop. So it is a problem, but you just have to sit with your patients and tell them that, look, this is important. This is not something that you don't take. So.
That's a huge message about the FDA because their mission is supposed to be safety, but the drug companies give them money. They are powerful lobbyists.
And the idea, and honestly, when I read in the transcript that it said that the FDA didn't have the authority to tell them what dose, I was like, okay, that's news to me. I thought the FDA had the ultimate authority in that, and I was completely wrong. Again, this wasn't some epiphany that I had. This was digging and looking, and I think that's one of the reasons that it attracted some of the lawyers to call me up and to ask, because I do believe that the drug at 20 milligrams once a day is excessive, and I don't believe people should be on it. Dr. Caleb actually made the statement, you wouldn't put my mother on 20 milligrams once a day. So it's interesting that is the drug that the dose is approved.
Joe Holoubek would be proud of you.
Other questions?
There's probably a lot of robust data now available after the drug has been used so much in real world. Lots of,
Post-marketing data.
Yeah, post-marketing. And I saw one piece of data that you showed that shows that Rivaroxaban. There are multiple other studies that have looked at Rivaroxaban in cardioversion patients and Afib ablation patients, and we don't see that. I'm not sure if that's because of the smaller data set, like the number of patients in those studies are
The
probably.
bleeding risk is there, and it's real. And when you compare Rivaroxaban to nothing, Rivaroxaban fares better. When you compare Rivaroxaban to well-done warfarin, Rivaroxaban at 20 milligrams once a day does not fare. when you compare it to Apixaban, Endoxaban, or Dabigatran, Rivaroxaban, there's not one trial ever, even a retrospective analysis, that shows any superiority of Rivaroxaban. And most of them either show no difference or superiority to the other agents. Again, my point isn't that the drug is a bad drug. My point is the dose is too high. And because Apixaban and Dabigatran have the same price and a very similar profile, and Endoxaban is once daily and the cheapest of all of them, why would you choose Rivaroxaban? And yet, a lot of people choose it. I mean, it's still there. You know, those. I have clinic at UMC every Friday morning. And every Friday morning I go in and there's a big stack of purple folders for Xarelto, and I throw them away. And every Friday, I come back the next Friday, and by golly, there's the stack of them again. I guarantee you I've personally thrown away 50 pounds of propaganda, and it just continues to find its way back. Thank you.